Yes.
Okay.
So
if you, we should start.
Yes, we can start. Let's start.
Okay. All right. So good evening, class.
Good evening.
This evening we are going to talk about neoplasia,
Okay.
which is a term used to talk about abnormal growth of cells. What in layman's language we term cancer.
Okay.
So neoplasia literally means new growth, and a neoplasm is defined as an abnormal mass of tissue, the growth of which exceeds the uncoordinated and is uncoordinated with the normal mass of tissues within that particular organ. So usually what we mean by neoplasm is a growth which is uncontrolled. That's basically what it means. Okay. Usually what they do is that they compete with the tissue for their metabolic needs. And so they act like a kind of parasite and depend on the host for their nutrition and blood supply. So, like I was saying, commonly when we say neoplasm, we mean a tumor. And so the study of such tumors is called oncology. And neoplasms are actually categorized into benign and malignant. Benign means not harmful. Malignant means harmful. And this categorization is based on the behavior of the tumor and then also its clinical prognosis. So, what does a benign tumor mean? We say that a tumor. We say that the tumor is benign when it is relatively innocent. That means that it is localized, it doesn't spread, and it can easily be cured by surgery. You can take it out, and then generally the patient survives. When it is malignant, another term for that is cancer. And usually they stick to the tissues around them and infiltrate the tissue. And they grow in a pattern similar to a crab. So you see that a crab extends its claws when it's moving. And it sort of gets its claws more infiltrates the tissues around it, and it can cause death. It doesn't, you can cure it, but it usually, the treatment, if you discover it early, it can be cured. Otherwise, it can be fatal. So every tumor, whether it's malignant or benign, it has two basic components. So if you take the tumor and you divide it or you section through it, it has the parenchyma, which is made up of the tumor, and then it has the supporting stroma around it, which is made up of blood vessels, connective tissue, which feeds the tumor itself. Now, looking at the nomenclature for benign tumors, usually if a tumor has if the name of the tumor has OMA, then it's usually benign, generally. So if the tumor is from fibrous tissue, for example, it will be called a fibroma. If it is from carcinogenous tissue, which is chondrocytes, it will be called a chondroma. If it is from epithelial tissue, it will be called an adenoma. So generally, if you see that OMA, it usually tells you that it is benign. So this is a papilloma, a growth of finger-like projections from the colon. If you have a polyp is a mass that projects from a mucosal surface. Akosia, remote, call remote again. Okay, back. Please give me a minute. I need to lower the TV. Oh, hurry up. Go and bring it quickly. Hey. Please give me a minute. Okay, sorry. So that is how the nomenclature goes. If you take a malignant tumor, usually the same nomenclature, but then this one has sarcoma attached to it if it is of connective tissue origin. So we can have fibrosarcoma, chondrosarcoma, squamous cell carcinoma if it is epithelial origin. Then adenocarcinoma. So if it is epithelial origin, is carcinoma. And if it is of connective tissue origin, it's sarcoma. Okay. But there are always some inconsistencies. For example, a lymphoma is malignant. But however, you notice that it ends with an oma. Then a mesothelioma is also malignant, but then the ending is an oma. So it sounds as if it is
benign,
but it's actually malignant. Okay. Then sometimes you can also have mixed tumor. So we said that the tumor can be connective tissue, maybe fibrous tissue, so it's fibroma. Sometimes you can have a mixture of both epithelial tissue and connective tissue. An example is a fibroadenoma of the female breast, which is a benign tumor of the female breast, and it is felt as a lump in the breast, which is mobile, and it is non-tender. This kind of tumor is a mixed tumor. It is a fibroadenoma, meaning that it consists of both fibrous tissue and glandular tissue. Okay. Now, the main reason, and histologically, if you look at the both cell types or both tumor types under the microscope, that is both malignant and benign tumors, if you look at them under the microscope, there are things on the cell that distinguish them. Look at their behavior clinically, they can also be distinguished. So basically, you can distinguish benign from malignant tumor on the basis of these 5 characteristics: differentiation, anaplasia, rate of growth, local invasion, and metastasis. So we'll take a look at these one by one. So basis of differentiation. So usually you'd realize that the tumor differentiates into the tissues from which it originates. So a lipoma is made up of mature cartilage cells. Okay, so basically you can say that a benign tumor has well differentiated tumors, but a malignant tumor isn't well differentiated. So that's the point being made here. So malignant tumors usually have different cell types, and they are usually anaplastic. So this is a rhabdomyosarcoma. If you look at the various cells on this slide, you see that even the sizes are different. And then if you look at the cytoplasms, they are also different. So for a malignant tumor, the cells are poorly differentiated and they are of varying size. But in a benign tumor, the cells are well differentiated. Okay, so these are further examples. Then the other thing that will help, so a well differentiated cell and is found in benign tumors. However, in malignant tumors, you have poorly differentiated cells, what we call anaplastic cells. So you find that in malignant cells. Now, if you look at the rate of growth too, most benign tumors will grow very slowly. They usually are not fatal, so they grow very slowly and don't give any problem. However, most cancers or malignant tumors, they grow quickly, they spread rapidly. So if you hear, for example, that maybe somebody had a brain tumor, for example, between the time it was discovered and the time the patient dies, it's usually very short. But if it is benign, you'd realize that It grows very slowly. Maybe it is discovered, it takes a while, patient is able to mobilize funds and surgery is done and all that. However, if you take a tumor like a fibroid tumor, fibroid is a tumor. It is a tumor of the connective tissue cells of the uterus. So it is called a leiomyoma. Now it is under hormonal influence. So usually it grows very quickly during pregnancy. And for those who have fibroids, when they get pregnant, they also experience pain because the fibroids grows very quickly and it outgrows its blood supply. So then the core of the tumor experiences necrosis because its blood supply is not enough to supply the whole tumor because it's growing so quickly. So eventually what will happen is that during the pregnancy, they might experience severe pain originating from the fibroid tumor because the hormones produced during the pregnancy help the fibroid tumor to grow quickly, in addition to helping the pregnancy also to grow. Akosia. Okay. So the other characteristic which differentiates benign from malignant tumor is local invasion. A benign tumor usually stays where it is. So it doesn't really infiltrate into the surrounding tissues. However, a malignant tumor infiltrates quickly into the surrounding tissues. Usually the benign tumor has a rim of connective tissue around it. So it's sort of a zone around it. But you realize that the malignant tissue goes into the tissue, malignant tumor goes into the tissue. So sometimes you can't demarcate where the tumor is and where the normal tissue is. So these are examples. Okay. Oh, Akosia. Oh, God. Okay, so when you look at this slide, you look at the picture, you realize that there is a mass which is clearly distinguished from the rest. Okay, so this is a fibroadenoma which was removed from the breast. So you see that the tissue is white and then you have a dark area above at the top. So when you look at this microscopically, you see that there's something in the middle, and then at the edge of it, you see some sort of compressed cells, sort of forming a rim around it. However, if you look at cancer, so this is the same. This is a breast cancer, so it's not the same patient. Feedback. So this is a patient with breast cancer. If you look, you can't clearly tell what is what. Okay, so this is a malignant tumor. Okay, the other thing that distinguishes is metastasis. So metastasis means that spread of the tumor. What this means is that if the tumor is in, let's say, the bone, or let me just use this example, if the tumor is in the breast, and then you find tumor deposits in the bone or in the lungs, it means that that tumor has spread to these areas, and that is what we call metastasis. So one unique thing about malignant tumors or cancers is that they spread. But benign tumors, they rarely metastasize. So this is a liver mass, a liver filled with a lot of metastatic cancer deposits. So the light brownish areas are the tumor deposits in the liver. And then you also have the darker brown, which is the liver itself. So we can ask ourselves this question: how do the tumor deposits spread? If you have a tumor in your breast, how does it get to your bone or to the lungs, for example, or to the brain? There are three main ways by which the spread occurs. It can either seed within the body cavities, or it can undergo lymphatic spread or hematogenous spread. So what do these mean? Oh, I didn't explain. Okay, so let me explain it. So seeding within the body cavity means that if you have the cancer in the liver, it spreads to the peritoneum. So you see that the peritoneum is a body cavity where the cancer is. And so the tumor deposits will spread to the peritoneum. And then from the peritoneum, it will move to the other organs in the abdomen. So that is seeding within the body cavity. The tumor can also spread through the lymph. Okay. And this usually occurs when they go into the lymph nodes. So for example, if you have breast cancer and you go for examination and you examine the breast, you would find a mass there. Then when you examine the lymph nodes in the armpits, you realize that those lymph nodes are also enlarged. And that will tell you that the cancer has spread from the breast to the lymph nodes. Then we also have hematogenous spread. And actually the hematogenous spread is what is very, very key to the spread to the other organs. So the breast cancer can spread to the brain, for example, through the blood. And this is what we call hematogenous spread. Okay, so this is a benign tumor of the uterus and a malignant tumor of the uterus. If you look at the diagrams closely, you realize that the benign tumor is well differentiated. It looks even, the cells look even. However, if you look at the malignant tumor, the cells look uneven, they are of different sizes, their cytoplasms are different, and in one or two of them, you can even see two nuclei present. Okay, so there's something we call cancer epidemiology. So the epidemiology of cancer is what tells us, is the study of the characteristics as relates to the population. That's what helps us to know that, for example, as you are growing older, your chances of getting cancer are higher. Or some types of cancer are more common in a certain sex compared to the other sex. Or they are more common in a certain race compared to the other race. So that's what we call epidemiology. And this is done from studying populations with cancer. Unfortunately, we don't keep very good data. So sometimes we don't even have some of these statistics. So if you look at this slide, you'd realize that in males, the leading cause of cancer is prostate cancer. And in females, the leading cause of cancer is breast cancer. However, lung cancer is of a comparable percentage in both sexes, 14% in males and 12% in females. So this statistics or this epidemiology is from the West. Obviously, in our setting, it will be different because we don't have a lot of women who smoke in our setting. So our picture might look different. Okay. So epidemiologically, to understand what happens, usually we look at environmental factors and we realize that a lot of cancers are linked to where the person lives. And usually it tells you that the geographical differences are what helps in determining whether some cancers will be prevalent in certain areas compared to others. The other epidemiologic factor is age. Most cancers would increase as a patient grows. So between the age of 55 and 75, that's where cancer starts coming up. And this is usually because there's accumulation of mutations. And we talked about aging and accumulation of mutations in genetic DNA abnormalities and so on. So as the patient grows and these mutations accumulate, they can lead to the cancer. However, you can also have cancers in young children. So leukemia is an example of a cancer that is common in children less than 15 years. You can also have osteosarcomas that is bone cancers. You can also have lymphomas which occur in children. Then heredity. Heredity is also very important when cancer is concerned. And where heredity is concerned, there are different types. You can have cancers which are inherited, autosomal dominant inheritance. Then we can also have familial cancers, cancers that they run in families. Then we have autosomal recessive syndromes of DNA, defective DNA repair. So if you look at the autosomal dominant cancers, retinoblastoma is one of them, a cancer of the eye that affects children. Then colon cancer, and then there's what we call multiple endocrine neoplasm syndrome and neurofibromatosis types 1 and 2. So these are autosomal dominant cancers. What this means is that once your mother or your father has it, definitely you also get it. Then we have familial cancers. So for familial cancers, it runs in the family. There's familial clustering of the cancer. So an example of this is breast cancer, then ovarian cancer and colon cancer. So what has been realized is that we haven't really discovered whether these are transmitted by autosomal genes or whatever. But what has been observed is that there's a pattern in families. And so these are some of the reasons why family history is also very important. Because if somebody, I know somebody whose mother had breast cancer, but she decided that she didn't want to have her breast taken off. So she started doing the breast self-examination, and then she'll have annual checkups. So when they discovered the lump, and they said because of her family history, they would want to take it out, she wasn't really in agreement. And eventually, she died of breast cancer. So these are cancers that are identified within the family, but there is no pattern of inheritance. What has just been realized is that it is present in the family. So other examples are colon cancer, ovarian cancer. Then we also have autosomal recessive syndromes of defective DNA repair. What this means is that there's a problem with how the DNA repair occurs, and it is autosomal recessive. So this means that it isn't all the time that once a parent has it, they'll pass it on to their offspring. Actually, what happens is that the parents are carriers, and if they are both autosomal recessive, then the children can pick it up. And so these are some of the examples that you have. It's just important for you to know that there can be familial clustering of cancers. I'm not going to really ask you, so give 2 examples of autosomal recessive syndromes of defective DNA repair. But I just want you to understand that cancer can run in the family. And there are 3 main ways by which it does this. Either is autosomal dominant, autosomal recessive syndromes of defective DNA repair, and then familial clustering of cancers. Okay. Then we also have what we call pre-neoplastic disorder. So pre-neoplastic disorder is a condition that precedes the development of cancer. So, for example, persistent regenerative cell replication. So example, you have a skin wound. You have a wound, you keep scratching the surface of the wound, then it will heal, then you scratch, then it will bleed, it will start healing again. What happens is that with the repeated regeneration and proliferation, you tend to have uncontrolled cell division, and that can lead to cancer. Hepatocellular carcinoma is also preceded by cirrhosis of the liver. So liver cirrhosis can later on lead to hepatocellular carcinoma. So we say that the cirrhosis of the liver is a pre-neoplastic disorder. That is, it is something that occurred before the cancer came on. Then you can also have hyperplastic and dysplastic proliferation. So an example is somebody who smokes. So when the person smokes, they cause metaplastic change within the epithelium of the respiratory system, and then it can lead to change in the way the epithelium is, and eventually lead to cancer. Or a patient who has ulcerative colitis or atrophic gastritis can end up with carcinoma of the stomach lining. So let's look at etiology. Etiology means the cause. So there are three classes of carcinogenic agents that have been identified. Carcinogenic agents means that agents which cause cancer. So we can have chemicals, we can have radiant energy, and then we can have microbial agents. Okay, so we'll look at them sequentially. But before we get to that, there are certain characteristics of carcinogens. So some of them would act directly. Some too would be metabolized into another product, and that product is what will cause the carcinogenesis or the cancer. So those products that change into the metabolic products are called procarcinogens. So they act by several means, by destroying DNA, by destroying cellular proteins, and so on. Okay, so we can have some carcinogens which act directly. So apart from the ones that act by changing into active metabolites, we also have those who act directly. So examples are what I've listed: alkylating agents, and then we have also anti-cancer drugs. So even though these drugs help to cure cancer, the drugs themselves can also cause cancer. So cyclophosphamide, chlorambucil, and so on. Okay. So these are the chemicals. Then we can also have radiation causing cancer. So examples of the radiation are the UV rays of the sun, which can cause skin cancer, especially in Caucasian skin or the skin of the whites, because they have little melanin, which our skin has a lot more melanin, so it filters out the ultraviolet rays of the sun and prevents it from acting on the melanocytes to cause cancer. Then we can also have X-rays. We can have nuclear fission, we can have radionucleotides, and sometimes therapeutic irradiation. What this means is that a patient has cancer and we use the radiation to treat it. That therapeutic irradiation can end up causing cancer. Okay. So how does the radiation cause cancer? It causes cancer by causing effects on the DNA, chromosomal breakage, mutations, translocations. Okay. Then we can also have microbes that cause cancer. So microbial carcinogenesis or cancer causation by microbes it's predated in history. So examples are leukemia, human T-cell leukemia virus type 1. Cervical cancer has now been shown to be a viral disease which is sexually transmitted. Human papilloma virus type 16 and 18. So there's actually a vaccine for this, which in developed countries they give to preteens. So girls are aged 11, 12, they give them this vaccine before they become sexually active. And in the Western cultures, they also give it to boys because of the tendency for homosexuality. So if you give it to the boys too, then you prevent it, because if it's a homosexual, if they are prone to homosexual whatever, then they also prevent them from getting it. Then Epstein-Barr virus has been linked to nasopharyngeal carcinoma and Burkitt's lymphoma, human herpes virus 8, Kaposi sarcoma, HIV2 is also another virus that causes Kaposi sarcoma, which is a cancer of the skin. Then hepatitis B virus causes hepatocellular carcinoma. And Helicobacter pylori, which is a bacteria, causes gastric tumor. So most of these are viruses. However, okay. So the body also has a lot of anti-tumor mechanisms. We have cytotoxic T lymphocytes, which kill the cancer, the tumor. Then we also have natural killer cells, which also come in to kill the tumor as well. Then we have macrophages. So if you want to look at how the body is able to fight off these cancers, the natural killer cells, the T lymphocytes and the macrophages, they are the ones that help. Then the body also has the humoral mechanism, the complement, and then the cytotoxic activity of antibody-dependent cells. So these are ways by which the body fights off against the cancer. But however, you realize that despite these, the cancer can still occur. Oh, sorry. Okay. So what are some of the effects of the tumor on the host? They can cause problems in terms of where they are located. They can also cause problems in terms of the function of the tissue where the tumor is. So for example, if it is a cancer of a gland which produces certain tumors, then it will produce excess of the tumor and cause problems. So for example, the thyroid gland, if you have cancer of the thyroid gland and you have excess thyroid gland production, that can lead to thyrotoxicosis. Or if you have a tumor in a place near a blood vessel, it can grow and block the blood vessel, leading to infection. It can also grow into the blood vessel and cause bleeding, or it can grow and cause ulceration. These ulcers can also become infected, so you can have secondary infection. Then the cancer can also drain the host by taking its blood supply and its nutrients, so the patient will lose weight. And so that is what is responsible for cachexia. So we'll look at clinically how we grade cancers. So the grading of cancer helps us to see the level of malignancy, and they are graded from 1 to 4 or 5. And this is graded by a microscopy. So it means that before you can grade the cancer, you need to do a biopsy or take a sample of it, look at it under the microscope, and then grade the cancer. Now, staging, however, is different. Staging has to do with the clinical prognosis or the outcome of the cancer. So if you stage the cancer, it means that you want to determine how bad this cancer is clinically. And the staging will give you an idea of prognosis. So staging is based on the size of the tumor and then the extent of spread, and then the extent of metastasis. So whether there's metastasis or not. So if you have two tumors, one is small and the other one is big, the smaller one will probably have a better prognosis compared to the bigger one. Then if the tumor, one has spread to the lymph nodes and the other one has not spread, the one that has spread to the lymph nodes would probably have a worse prognosis compared to the one which hasn't spread. Then of course, presence or absence of metastasis. If the tumor has spread to other parts of the body, let's say breast cancer, and it's spread to the brain, and you know that it's a bad prognosis. So the staging is based on clinical and radiographic evidence. So clinically, maybe you examine the breast, you palpate the armpits, and then you find that there are lymph nodes. Then you do a mammogram, and then you also maybe do a CT scan, and then you realize that, oh, there are some deposits in the brain. So these things help you to stage. However, if you want to grade the breast cancer, it means that you have to do surgery, take the lump from the breast, look at it under the microscope, look at the behavior of the cells, and that will help you to grade the cancer. So there are two different things. So two methods of staging are in use. We have the TNM system and the American Joint Committee system. The TNM system looks at the tumor, the nodal spread, and then the metastasis. So that's what TNM stands for. Tumor, nodal involvement, metastasis. So for the tumor, we can have various sizes, T1, T2, T3, and T4, describing the size. So T4 is bigger than T1. Then we also have N0, N1, N2, N3. So N0 means no lymph nodes are involved, and N1 to 3 means progressively advancing lymph node involvement. Then for the M, which stands for the metastasis, is either it is present or not. So M0 means there are no metastasis, and M1 means there are metastasis. So maybe you can have a tumor where you say that the tumor is T1, N0, M0, meaning that the tumor size is small. It is N0, no lymph nodes are involved, M0, no metastasis. So that's an example of the TNM system. However, the AJC system it lumps everything together and divides the cancer into stages, stage 0 to 4. And so if you take a typical cancer, for example, stage 0 has specific definitions with respect to the tumor size, the lymph node involvement, and then the metastasis. So, for example, this is an example of staging of a neuroblastoma. So, stage 1, the tumor is confined to the organ of origin. Stage 2, the tumor has extended beyond the organ of origin, but it does not cross the midline, and the ipsilateral lymph nodes may or may not be involved. What this means is that ipsilateral means that the lymph nodes on the same side of the body as the tumor are not involved or may be involved. Then for stage 3, the tumor extends beyond the midline, and then the lymph nodes may or may not be involved. For stage 4, it has spread to distant viscera. For stage 5, the tumor has spread to the liver, the skin, or the bone marrow. So how do we make a diagnosis?